So, of the available techniques for detecting early disease, and of course the goal here is to institute early interventions to try to limit the eventual expression of disease. Most of the things we've already talked about are available in one format or another in principle. I think most centers would have difficulty setting up volume displacement unless it were part of a research study that were ongoing, and the equipment is typically not widely available. It's, as I said, it's cumbersome, although once the tank is available, there's little additional cost. Just simply not easy to do repetitively, requires a tremendous amount of space and manpower to make it happen. Physical exam, of course, is always available, but it's a relatively late and relatively insensitive indicator of early disease. Spirometry is available. I think expense is an issue, and strictly speaking, the FDA approval of this technique for the detection of early disease is not present. Bioimpedance spectroscopy is increasingly available, is FDA approved, and has the distinct advantage of being both quite sensitive to early disease, having great portability of either the device to the patient or the patient to the device, and quite amenable to repetitive interventions with the patient in order to serially evaluate risk during those early months and years that the patient is at highest risk. There have been studies of patients with breast cancer at risk for developing lymphedema who are serially observed with bioimpedance spectroscopy using population norms to define the threshold at which the concern for disease exists. And typically in those studies, 3 standard deviations beyond the population norm was defined as the upper limit of acceptable values, looking at ratios of bioimpedance from the limb at risk to the normal limb. When one identifies individuals who cross that threshold over time, the likelihood of developing lymphedema from that time point is greater than 99%, and that typically occurs in a very short time frame of, let's say, 12 to 18 months. So the ability to use this technology to identify individuals who are predestined to develop overt evidence of the disease is extraordinary because it allows the therapeutic intervention even before disease becomes established at a clinical level. I think it's only fair for me to say that this application of science to clinical practice is one that has excited me for a long time. I think it's a marvelous application of basic principles into a very usable tool that can be of extraordinary help to clinicians at the bedside, and I think that we need to embrace it as a technology that will help us not only as clinical scientists but also as clinicians. And not only in breast cancer, it has its most clear and precise application today in breast cancer, but there are many other medical and surgical conditions that predispose patients to lymphedema over time in which this technique is going to be extraordinarily useful. So patients who have intra-abdominal and pelvic operations, and specifically malignancies like gynecologic cancers, are also prone to lymphedema of the lower extremities, and this technique is surely going to be proven to be useful in that realm as well as we develop better technologies to monitor both limbs at risk that will become even more useful. I really think that the future is bright for the application of this technology and would encourage clinicians and scientists both to use it broadly so that we can best help the patient population.